Welcome back to Clinical Communication. Today, I'm speaking with Matt Wedderburn, who is a first contact physio and also founder and director of Primary Care MSK, which provides a wide range of support and training on how to manage patients with musculoskeletal conditions in primary care. On this episode, we're discussing the communication challenges that can occur in first contact practice, whether that's managing expectations, managing time, managing uncertainty. If you find this useful, please do share it with others. Please do subscribe. Please do send in any questions, stories, or requests to clinicalcommunication@outlook.com. Thank you, as always, for watching or listening, and I'll speak to you next time. Yeah. Thank you for doing this, Matt, and giving up your
No, no
time this evening
problem.
and
No
speaking to
problem.
me about this very interesting topic of when an FCP and when time is limited, about how we communicate with people. We got an interesting group of questions to cover, and one of the first things we're going to start with, which is, I guess FCP is now what, 5 years old, 6 years old? How old is it?
Six,
Six.
I believe. Yeah.
But I presume, I mean, when I talk about it to patients, they're still like surprised a lot of the time. I presume people still come in saying, "What is this?" or "Who are you?" Um, how should to have, I say, John come in to see his FCP for his knee pain and says, what is this first contact physio? What does this mean? Um, what should we tell him?"
I think firstly, it's really important that you do it. You've got to tell them what the role is because if they don't understand, then you're going to have difficulty managing the consult as a whole, really. But look, we're in a time really where patients are seeing they don't see a regular GP anymore. They might see the GP, they might see a locum, they might see physician associate, ACP. A lot of the time, they don't know who they're seeing unless it's been well explained to them by maybe the receptionist or the booking team. But you need to explain to the patient, look, or ask them, at least first ask them, do you know much about FCP? Do you know what this role is? And then if they don't know, you can expand on there. And essentially, there's different ways you can do it. You can, I'm sure everyone has their own sort of versions of doing it, but I would try and keep it nice and simple. I try and avoid terms like musculoskeletal specialist because they'll probably ask you what's a musculoskeletal specialist. So I'd just say, look, I'm a specialist clinician trained in assessing and managing muscle pain, joint pain, bone problems, or nerve pain, like what
Mm.
you've come in to see me with today. And essentially, our job is to help the doctors manage these conditions a little bit more effectively to make sure you're getting the right care first time. Essentially, that's what this job is created for. We can arrange investigations, we can arrange referrals, we can link in with our colleagues for prescriptions. Unless you're a prescriber yourself, you might not say that. So anything that's required, we can sort of get that done. So generally, you're in good hands, and I'm the right person for you to see. And I've never had anyone have any qualms with that. And for some people, you might not need to go in that much detail. I'd just sort of gain an understanding of what they think it is first, and then you
Mm.
can expand on that.
And we know, it's 5, 6 years now, but there will be certain members of staff that will be new to primary care as well
Mm.
while as this is going along. Whether that's other doctors, nurses, as you say, APs, whoever. They may not have heard of a first contact practitioner or physio before. Do you give the same explanation to them, or is it a different?
Well, yeah, a little bit more medical. I'd
Oh,
probably just say, look, we're advanced MSK. Most people know what MSK is, so we're advanced MSK clinicians. We're embedded into this primary care setting to essentially reduce the burden of this on you guys. So we know that around 30% of consultations are for GPs or MSK conditions. So we're there to sort of take off the load from that, and we can work collaborative. Well, we do work collaboratively with the rest of the team, and like I say, we can arrange X, Y, and Z, and that's pretty much what I would say to them, and they get it straight away. It's making sure they don't think you're a physio service.
mm,
That's the main thing. If your colleagues think you're a physio service, and maybe you've got clinicians referring patients in to see the physio, and the
yeah.
patient then comes with different expectations, and maybe the actual clinician's got different expectations of what you do, that's when it gets a bit tricky. So the whole team has to be on board with what the role is, what it's there for. Most of the clinical directors will know clearly what an FCP is, but like you say, the newer staff might not. But the key, if there's anyone who you need to train on what the role of the FCP is, it's the reception team and the booking team. Those are the
Ah,
ones that will make a difference, because those are the people who decide who sees FCP and refers in, and when sort of they refer into an FCP. So they're key to the effectiveness of the service, really, because if you've got a reception team who doesn't really know what the FCP is, they might not refer in, and then
mm,
you're not making it a cost-effective service, because these patients are still ending up seeing the GP first and coming through to you from the GP, which is not what an FCP service is
mm,
about. Or you've got patients coming in with poor expectations, like I say, thinking it's a physio service, and you've got a battle on your hands straight away then, because this patient's come in the shorts waiting for
yeah,
waiting for a hamstring rub. Do you know what I mean? So
yeah,
you've got to get the reception and booking team on board first. If you had to focus on one area, that would be my recommendation.
really,
And then obviously the rest of the team need to know, but those are the key influences for how the service will work. Because if your reception and booking team know exactly what the service is and who can go in to see them, you're not going to get many referrals from other clinicians anyway, because they're not seeing them first, they're seeing you.
yeah.
Um, so yeah, those are sort of the ones that you should be focusing on, because the last thing you want is poor utilization, high DNA rates, and then you've got the clinical directors or PCM managers thinking, well, what are we paying for this
Yeah.
service for, essentially? So yeah, you've got to get it right.
It sounds like it depends on who's triaging it. Is that right? Who's
Yeah, yeah,
directing it? Because I presume in some, does it depend on what the service is and how patients refer themselves in? Because I presume
yeah,
there's some services, be honest, like mine, where rather than phoning up, you it's all online. You message, and then someone, whether it's a nurse or GP in the practice, will see it and then put you with whoever they decide. Um, it was a case of making sure whoever's making that decision knows what the FCP's role is and what's accurate.
Yeah, 100%. There's different ways of doing it. Different practices will do things differently. So most of the practices I work at have care coordinators. So that's their job role, is to go into the online e-consults and filter things out. Some practices where you have an online service, like an e-consult service, when the patient fills in what the issue is, it will automatically, I don't want to say AI triage, because it's not AI, but it will electronically pass it into FCP if it says shoulder
Mm.
issue. But then you would still have someone who would check in and make sure it's not, I don't know, I've got a mole on my shoulder, for example. So you've got to make sure the care coordinators, like I say, the reception staff, care coordinators, and whoever is triaging. There might be some practices work with a GP who triages, who will um, know what the service is about, generally speaking, because it'll usually be an experienced GP doing the triage. Um, so yeah, it's just making sure all those involved in who refers and decides who and when gets referred into FCP is key, really.
And let's say, hopefully, we get referred the right people. They come in, speak to whoever you need to speak to. Now, this appointment, is it across the board that this appointment's for 20 minutes? Is that right?
Generally, yeah. So
Yeah.
where I work, all clinicians, it's 20-minute appointments for a service, unless the practice doesn't want that. Unless the practice wants, let's say, 30 minutes. Different trusts can work differently. Like, some might be 20 minutes, some might be 30 minutes. I know someone who very well, actually, who does 15-minute appointments now. I don't know how he does it, but
Oh, wow.
that's sort of how they work. So yeah, it's tight. It's a tight time schedule, um, but it's manageable. It's not as challenging as people think. I would say
Okay.
15 minutes, I think, would be. 20 minutes is definitely manageable.
How do you manage the 20 minutes? Because there'll be a lot of people listen to this who are used to, I don't know, 45, or me, like an hour. Um, so how do we manage those 20 minutes without that patient? You know what they say all the time. I only had 10 minutes with the GP. They just rush me in and out, and so that's what people say all the time. How do we again have that limited time frame, but make sure they don't feel rushed?
Yeah, of course. I mean, it's easy. It's easier than you think, like I said, but a lot of these patients are seeing GPs and they get 10-minute appointments. So they're getting double when they see us. So
Mm,
already they feel better because they're getting 20 minutes. But essentially, it comes down to you as a clinician and getting to the crux of the problem relatively quickly
mm,
by using your open-ended questions. They'll tell you what's going on. They don't want to waste their time as much as you don't want to waste your own time. So get to the crux of the problem, make sure they're not going to die or they need to go to A&E,
Yeah.
and then sort of work from there. Really, we know that about, what is it, 75-80% of all diagnoses come from the subjective assessment,
Yeah.
and then you're just using your objective assessment to negate or confirm your hypothesis. Really, I mean, look, something I preach, probably rightly or wrongly, is that I think people overcomplicate the FCP role. It is an advanced role. You have to be an experienced clinician, minimum band 7, good clinical mileage, excellent sort of pattern recognition, because common things are common for a reason. You will see a lot of common things, but you've also got to know when something isn't right and when to
Yeah.
have that level of suspicion.
Yeah.
But we don't need to be, we're not there to be a specialist in a specific area. We're there to be, this is my view, others may agree, others may disagree, but we're there to be generalists. I would class myself as a generalist. I'm not a shoulder specialist. That's why you get referred on to secondary care to see those people. I know a little about a lot,
Mm.
essentially. But I know when someone can self-manage. I know when someone might need a little bit more workup before we make a decision,
Yeah.
or I know when someone needs a referral onwards. And it doesn't take long to find out if someone has mechanical back pain or risk factors for, let's say, an AXPAR or something else. It's not that, like I say, you'll pick that up in the subjective. So those 20 minutes, it's quite a long, well, it's a lengthy bit of time if you know what you're doing. It's the people who struggle are the ones who feel like they need to do everything
Mm.
in that 20 minutes. So they're asking every clinical question they can think of because they don't want to miss anything. They're doing absolutely every objective test they can do because, again, they don't want to miss everything. And then, like I say, they're overcomplicating things. They don't really know which way to go. Then they've not done the consult well, so that they don't know what the patient's ideas are, like their ICE questions, and they don't know
Yeah.
how to match that up with their expectations, and they've got a bit of a battle on their hands, and then before you know it, they're already 35 minutes in, and the patient's still there in front of them. So it's easier than you think if you're an experienced clinician, but it takes time to build that up. When I first started as FCP, I did struggle. I quite like being thrown in the deep end uh, and learning, because sometimes you need to learn that way. But yeah, once you get into your head that we don't need to overcomplicate things, um, my view is that it can be managed quite easily within 20 minutes, as long as, like I said earlier with your eye stuff, is that you care,
Mm.
you're listening to the patient, and you're managing their expectations and their pathology or symptoms appropriately.
Like you said about the open questions. So, and I can hear some people thinking, oh, if we ask them open questions, they're going to give a 3-minute answer. Um, Now, my feeling is that open, and there's lots of evidence for this, is that open questions don't take any longer than asking direct closed questions. But is that your view, or what's your thoughts? Does it?
Yeah, 100%. You've got to ask them. They'll tell you most of the stuff if you ask an open-ended question. Why are you here today? How can I help?
Yeah.
They'll tell you straight away what the issue is. Um, and then if when you need to get a little bit more specific, I don't let them talk for 10 minutes. I don't ask them one question, let them talk for 10 minutes. Let's be realistic.
Mm.
And they won't anyway, generally speaking. So you might need to guide them a little bit, but they'll give you most of the history and most of the present complaint within those sort of 3 minutes of open-ended questions.
Mm.
Um, and although we're trying to get that information from them, the reason we're asking the open-ended questions is because we're also trying to build that rapport and that connection with them. And if we're doing like the research suggests, where we're interrupting them after 30 seconds of that first opening question, they're already not going to be too happy with that. And then, like I said, in a 20-minute consultation, that rapport and trust and confidence in you and a clinician is key. You've got to get it right straight away and pretty
Yeah.
quickly.
Yeah.
There's no room for error really with that side of things. But yeah, if you ask those open-ended questions, get what you need to know from them, and then you can start to signpost the consultation into your more specific stuff. Now, a great mentor of mine, a GP that I work with, has done a bit of work with me over the years and sort of mastering the consultation. He's amazing to watch in clinic, but he often talks about signposting the consultation, and instead of being sort of open with your questions and then maybe the closed one and then open again, he sort of starts with open, suggests we start with open, and then we narrow it down and start to hone in on the
Yeah.
questions that we need to ask. And you do that by signposting with your words. So you tell the patient, look, I want to ask you a few specific questions about your knee now, Margaret. Is that okay? And get that confirmation from them, and then they'll zone in, they'll lock in because you've told them that's where things are going. But then you also change your posture as well with how you do it. So when you ask your
Oh,
open-ended questions, you sit quite open, relaxed. But
yeah.
then when you need to ask those specific questions, you bring your hands in, you lean forwards, and you say, "Look, Margaret, I just want to ask you a few questions, a little bit more
Oh,
specific now about your knee. Is that okay?" And you've shown them that we're focusing in now. They need to pay attention, and they'll listen. They'll answer it. They won't go off on tangents. They won't start talking about the granddaughter's graduation. They'll focus on those questions that you ask them, and that's when you get the things you need to know. You do your red flag screening, and then you can start to move on to their ice and how
yeah.
it's impacting them socially and stuff like that. Um, so yeah, that's how I do my consultations. But I've been lucky enough to learn from some amazing clinicians, like I said, um, and put it into practice, and it works. So
Yeah.
yeah, that's sort of how I practice.
Yeah, we have we call it an open, you go from an open cone to a closed cone with these questions.
Mm,
If you I've never heard of the leaning back for the open and that's yes, it's been like with the closed questions, leaning and you're focusing in a way.
yeah,
So
exactly.
that's good. Very
It's
good.
like what we said with a lot of the stuff, how we communicate is non-verbal, isn't it? Body
Mm.
language and the tone of voice. So if you can combine the body language with you directing it verbally, it does work quite effectively.
And we can build doing that and obviously listening, as you said, and like body language, we can build rapport and trust in 20 minutes.
Yeah, easily. Yeah, easily. Yeah, you've got to have fun as well. You've got to have fun, have a bit of a laugh with them. Like you don't have to be quite often. Um, we we can be seen that you need to be too professional. You can't have a laugh. You can't talk about your own life. I often will. I'll talk about my daughters. I'll talk about things that I'm doing outside of work or in work. Because at the end of the day, we're humans. You've got to connect with these people, and you've got to
Yeah.
find ways to connect with them. And sometimes having a bit of a laugh and a joke and having a bit of, if the patient wants to, that's when you started looking at like the mirroring and matching their energy sort of thing if they're up for that sort of conversation. But yeah, you've got to have fun with it. But yeah, building trust and rapport in 20 minutes is tough. I won't say it's not. I won't say it's easy,
No.
but once you know what to do, I don't think it's too hard. It's quite easy to put into practice.
And there's time to talk about, as you say, kids or life or, non-clinical things, so to speak.
Yeah, 100%.
Oh,
Yeah,
interesting.
100%. I always introduce it, and I think to me, other people practice. Everyone practices in their own way in terms of how they do things like note like typing the notes when they're asking questions. I've gone through a period over the last probably 6 months where I don't type whilst I'm talking to the patient, and that I feel like I've got more time. I feel
Mm.
like I've got more time. I know people type because they're trying to save time, but actually I get more time from doing that, and that's when you can have more of a connection and a proper chat with someone. And like you say, you can share your own experiences. And like I say, we're not talking about going into talking for 10 minutes about what I did over Easter weekend, but just sharing little insights into your life and, like I say, maybe how you can relate to theirs. Um, but yeah, building trust in 20 minutes, I think, is easily done if you know what you're doing. But it's not as easy as maybe um, a private clinician working in sort of a private MSK clinic where they're going to see someone once a week for 8 weeks. You've not got that luxury. You've got to get it right first time, essentially, which is the hard thing.
Yeah, yeah. Um, and one of the, I guess on that note of having making sure we have enough trust, because we want them to have as ideally as much trust as possible, and that's where it's, because there's a lot of, especially in primary care, uncertainty, especially you're the first person seeing them. So this is actually a question that was sent in to me that I'm grateful you're here to help me answer. If we've got someone come in, we're seeing them in primary care or seeing them for the first time with this issue, and we're a bit uncertain about what's going on, how do we discuss that with the person in
Mm.
front of us?
Yeah, discussing uncertainty is a good topic. It's an interesting topic, um, because you'll get patients coming in and they want an answer. They want one of the four things that patients want to know from you is what's wrong with me. And if
Yeah,
you can't answer that, as physios, we want to help people, or we want to feel like we know the answer to all the questions, and sometimes we don't.
Mm.
Um, but if you follow a good framework, if you like, in terms of how you manage your consultation as a whole. So when I come onto my management plan, so after I've done my subjective, after I've done my objective, you've got to tie your management plan back in with ICE. So whatever their initial ICE was, and it might be that you had Margaret, let's say she's worried she's got a meniscal tear, and you might say, look, from my examination, your symptoms, I know you was concerned about a meniscal tear. Well, actually, good news is your symptoms present classic of whatever it is. But if you're a bit unsure, you've got to verbalize that and you've got to share your thoughts. You say, look, I want to share my thoughts from what we've gone through today. Um, first of all, it doesn't present as anything worrying or concerning. And I think there's three possible reasons as to why you've got this issue. And I'll discuss what those three possible things are. The first thing is it's this. So it could be OA. Second thing is it could be a meniscal tear.
Yeah.
Third could be both, let's say, as an example. And then you say, well, in terms of managing that and how we get to the answer of that, this is what we're gonna do, and this is what I'd recommend, and they'll be happy with that. And you'd say, well, look, would you agree with that? And they'll say, yeah. So you might say, well, what we're going to do is we'll consider arranging an MRI scan or referring you on to the integrated MSK team to consider an MRI scan, so that we can actually find out what's going on with your knee. Does that sound okay? Yeah, great, perfect, done.
So I'll do. Is there a lot of reassurance in the role?
Yeah,
Yeah.
yeah, yeah, yeah. You as with a lot of stuff, as with any sort of physio role, there's a lot of reassurance. Um, People want to know that their issue isn't gonna. This is why ICE is so important, because what they want to, a lot of the time, it's the impact of the symptoms that's the main concern. It's not the people can deal with pain. It's
Mm.
how this is impacting on work. Am I going to need surgery? Is it going to mean X, Y, and Z? Am I going to be like this forever? Blah
Mm.
blah blah. The list goes on. So reassurance is key, and there's two ways you can give them reassurance. You can either use stories. So you might say, "Oh, look, I had a patient exactly like your symptoms exactly the same as yours 3 months ago. Now they're doing really well. This is what they did X, Y, and Z." Or you can use facts and use the stats and figures that are out there for saying, "Well, look, actually, let's talk about imaging for a second. Like these degenerative changes are common in anyone over the age of X, Y, Z. So do you know what I mean? We can start to normalize things and give them reassurance, and you've got to sort of lean to what you think the patient wants. Do they want more of that
Mm.
storytelling side of things, or do they need a bit more facts and figures? It can differ from person to person, but yeah, reassurance is massive. But that's why you've got to build that trust and rapport with them at the
Mm.
start of the consultation. Everything comes back to how you do your subjective and build that rapport, and that all happens within the first 5-10 minutes.
Mm.
Because if they're confident with you, in terms of they're confident in you as a clinician, you've listened to them, you've done a good objective exam or a subjective and objective exam, sorry, you've told them what the diagnosis is, you've told them what you or you collectively are going to do about it to help manage it, you've safety netted them. There's not going to be any pushback really. They're probably going to be quite happy with that. So yeah, you've got to build it all together. You've got to get it right from the start, really.
Do many, I guess, because it's a newer role, I say new, it's 5 years, but it's not as a known role. Do many want to see their GP instead of the FCP, or by the time you've finished, is that they change their mind?
Uh, Very rarely I'd see someone and they'd want to see a GP after the consultation. You might get the odd one come through who says, "Oh, well, I didn't know I was seeing you today. I asked for an appointment with a GP and I've ended up seeing you." And that's when you go back to what we was talking about earlier about educating them on the
Yeah,
role.
yeah.
Um, but the main two reasons why someone would want to see a GP is either one, they don't understand the role, and two, you've not built that trust and rapport. Those are sort of the main two reasons from my point of view as to why they'd want to see a GP. But if you've built up good relationships with your practice, the MDT understand the role, um, they would back you up and say, look, this Matt is the best person to see for this condition. Most times you'll get things like that. But you've just got to, same with most stuff, you've got to roll with the resistance. So if a patient comes in and says, oh, I wasn't expecting to see you, I want to see a GP, you just right, yeah, okay. I don't blame you. They're brilliant, yeah. But look, instead of wasting your time, why don't we just let me ask you a few questions? As long as you're happy with that, I can have a look at you, and we can. If you still want to see a GP after at that point, that's fine. It'll help the GP if they've got my examination and notes to go off. Is that all right with you? Just roll with it, and they'll say, yeah, it's fine. They've got nothing to lose. They're there already.
Yeah.
But then after you've done that, um, I can't think of a time that they've still wanted to see a GP afterwards
Oh,
because they're
fine.
happy with everything that you've said and done. Now it might be different for other people. Um, there may be times that maybe I don't know, maybe they have still wanted to see a GP afterwards, but they've just not told me and they've gone through the receptionist. I don't know. But yeah, if you put the legwork in, roll with the resistance, build that trust and rapport. Um, Often patients are happy with what you say and happy to go with the plan and the options that you've discussed.
Are there any other major challenges in communication challenges in FCP? Big one I hear people say is time, which we've discussed,
Yeah,
and expectations.
those are the main things really. Time, expectations. The main, like I said, the main battles really you'll have is if they don't understand the role. But that's when it goes back to making sure that the FCP is well embedded within the service. Like I say, the care coordinators, the admin, reception team all know who and what should go through to see the FCP. Um, but I'm trying to think. I mean, yeah, it's usually that and time, because sometimes some patients do take a little bit longer than others,
Mm.
and you can feel that you've got to rush things, and it's difficult because some clinicians don't like running over and they want to be very regimented. But I mean, I'll have it where I might spend 30 minutes with one person because maybe they need it, but then my next patient's takes 10 minutes. So
Yeah,
it does balance out usually throughout the day. You will get sort of admin and catch up time, but you've got to be okay with that. You've got to sort of accept that sometimes I'm going to run a little bit late, but actually for this patient, it's worth it that we spend a little bit more time here.
yeah, yeah.
Um, so yeah,
It's
I
okay.
can't
It's
think of
okay
any
to be.
others.
It's okay to be flexible with time. I guess. I mean, everyone thinks about if they go to their GP appointment, you're going to be potentially waiting at least half an hour, aren't you?
Yeah,
Not
exactly.
always, of course. Sometimes they do run on time or early. But I think it's so, I don't know, built into our expectations now. It's like A&E as well, isn't it? You know, you're going to be there for a while. Um, that it's just, maybe it's expected.
Most
Um,
people are all right with it. If you say, "Look, oh, I'm sorry for your wait," but it's fine. Yeah, it's fine.
yeah, yeah.
I've never had any major issues with it. It's more yourself that gets worked up and stressed about it, and that's when you can start to make bad decisions when you're rushing, and like you say,
Mm,
you threaten ruining relationships because you're trying to churn through the patients to get back onto schedule. Whereas if you just accept that some days I'm going to run a bit late, some days I might have to eat my sandwich whilst I'm sending some tasks over, doing some admin work, and that's just part of the job and it's okay, then you'll often find that since I've took on that mindset probably over the last couple of years, I enjoy my job a lot more and it's not as
mm,
stressed, it's not as challenging. So if you take a different mindset, often it can be a lot easier.
Interesting. All
That's
right.
just my points, my thoughts.
Yeah, that's good. That's good though. You don't have to be as regimented. That flexibility, I
Yeah,
guess.
exactly. Yeah, exactly.
Matt, I ask everyone this. I mean, it doesn't have to be FCP related. But what's been your hardest clinical conversation?
Yeah, I was thinking about that one for quite a while. It's tough. As physios, we have lots of them, don't we? We have lots of challenging conversations across the board, and we probably all have quite a lot of similar ones as well. But I've got a notoriously poor memory, Ben, so I'll try and think of one that I saw recently. I'm
Okay.
sure I've had tons in the past. I'll tell you what, actually, no, I did have one that does stand out that I was thinking about, which was one that made me want to learn a lot more about communication styles. And this is what actually got me in touch with um, the GP mentor that I was talking about earlier and wanting me to go and shadow his clinics. But this was someone who's probably your bread and butter, which we can see a lot in primary care, sort of your widespread persistent pains. But generally speaking, it's the ones who have maybe expectations that don't fit with what's appropriate for them. So I had a lady who had widespread pain, had every test under the sun, had been seen by orthopedics and rheumatology and pain clinic, but still struggled with this pain. And they still come back to primary care and say, look, I'm in pain. What are you going to do about it, essentially? Um, and it might be that things maybe hadn't been explained well to her in the past. I think she'd been told that she'd had fibromyalgia, but they still look for this answer. Um, and as an FCP a few years ago, I was definitely not as good of a communicator as I'd say I am now. I mean, I've not, like I say, I've not done any formal communication training. This is all just sort of stuff I've learned through practice and through mentorship and learning from others. But when I think back, I was definitely a poorer communicator back then. I just wanted to make sure that this patient was safe and that I didn't miss anything, really. So I'd done full examination of her. I'd done full neurological exam, made sure nothing concerning was going on, and felt like I had to give her something, and
Yeah.
just sort of said, look, one option we've got is referring you on for physio. Um, and this lady pretty much stormed out the room and said, well, that was a waste of time. um, and that sort of stuck with me. And I was like, how do we manage those patients? Like, why are they so challenging? Why are they so difficult?
Yeah.
Um, what am I doing wrong that's going to help um, improve that? And this lady, like I said, had tried everything, and I was quite scared to open Pandora's box on her. And I'm sure a lot of clinicians get
Um,
that, where you sometimes you sort of you sense there's a lot going on, but you almost don't want to ask because you know it goes back to that regimented time thing where this is gonna just take forever, and you
mm,
know that it's all gonna pour out. Um, so perhaps if I actually spent a bit more time digging into her ice and finding out what's going on, how it's impacting her socially, with work if she worked, um, with family, etc., and perhaps things would have been a lot different. But like I said, I felt like I had to offer her something. But now I've sort of learned that maybe sometimes doing nothing can be just as powerful.
yeah.
Um, we don't have to do something all the time, but as physios, we want to fix. I think that's sort of drilled into us. We want to
Yeah.
find the answer. We want to fix things. You don't need this. You don't need that. We can sort you out. Um, so yeah, I think that was just sort of naivety and um, just something you learn as you progress throughout your career, I think. And now I have the confidence to ask those questions and dig in a little bit more, and not afraid to ask them how that's impacted them. How what do you feel about that? How's that impacting you on X, Y, and Z?
Yeah.
And even sort of they're saying, I can't remember who I learned this from. I don't know if it was you or someone else, but someone mentioned sort of saying, with people with persistent pain, just asking them, has anyone ever told you that this pain might not go away? And just sort of letting them sit with that for a minute.
Yeah.
And that can be quite powerful as well. And um, some people can be quite accepting, and or can be quite emotional with that. And you can start to dig into that a little bit more. But yeah, those are the ones that generally I struggle with, still do struggle with. I'd say I'm better now, but I still struggle with them.
Yeah.
As well as the, like I say, the like I say, the expectations of things where it just doesn't really match with what we can offer or
Yeah.
what's appropriate.
Yeah. And yes, what's suitable for the search for the
Mm,
situation you're in, so to speak.
mm,
It's fine when, this is where we have specialist services for whether it's just pain, but whatever, where people have more time to dig, so to speak.
mm.
But it sounds like what you were saying there, that actually, even, and you were saying this earlier as well, even if you only have 20 minutes, it's still, can still have the time to dig and, open Pandora's box, to use your words, and
Yeah,
kind of identify some factors that will be impacting rather than just pushing it away. Is that right?
100%. Yeah, 100%. You've just got to bear in mind that, look, this patient might take a little bit longer. I might be 10 minutes behind schedule. Um, or you're actually quite reassured that everything that's already been done, nothing's really changed. Maybe we don't have to go and do every objective test here. We can ask them, obviously, a few red flag questions, make sure we're just asking those specific ones, but then leaving the rest of the consultation open, and just listening. And sometimes those persistent pain ones, I mean, you can't manage them really in primary care for just a one-off appointment unless you're sort of passing them on to someone like yourself or a pain
Mm.
sort of service where they can get a bit more support. But sometimes I'll book them in for a follow-up. I might just say, look, why don't you come back and see me? Plant some seeds, and come back and see me, and sort of see if we can address some of the other stuff that we can make a difference with. So diet, exercise, social well-being, etc., linking in with social prescribers. So there are lots of stuff that we can do, and it doesn't have to be something medical, but they have to be ready to engage,
Yeah.
obviously. And I'm sure you've had it before where someone comes back, um, well, they've seen you and they weren't ready to engage, and they come back maybe at another date and they actually are now because
Yeah.
they've tried a lot of stuff and think actually, I'm ready now to accept this and try and live a better life with this persistent pain. But yeah, I'm far from a specialist in persistent pain, but uh, I've tried to improve on how I manage those patients because you've it's quite easy to dread them. A lot of people do dread them because they're challenging, because they're hard.
Although, to be fair, people with shoulder pain can be challenging, and
Mm,
knee and ankle pain can be challenging, and um, yeah, I guess it's what we get comfortable and used to seeing, isn't it?
mm,
Um,
percent.
I find it. You were saying about managing them in primary care. That's like part of the fibro guidelines, isn't it? That they should be diagnosed and managed in primary care. I'm thinking diagnosed, okay, managed. I don't know if a 20-minute FCP appointment is enough to manage someone's long-term widespread pain. I know you've got all the other members of the MDT and stuff, but
Mm,
as you say, I do like how are they defining primary care in
mm.
that instance? Um, yeah. The last thing I was going to ask was, what do you see the future of FCP as?
Future as FCP. I think. I mean, look. I think the role here is it's here to stay. I mean, there's been talks with some of the changes to, like the R's reimbursement scheme and being able to use GPs now within that sort of funding pot. But I mean, research consistently backs the cost effectiveness and the clinical and cost effectiveness of FCP, and the knock on benefit for the rest of the healthcare system with like the reduced referrals, reduced imaging, prescriptions, etc., etc. So I think the research and over the last 5 or 6 years of doing it and the earlier trials has shown how beneficial it is. And a lot of the practices that I work and my colleagues work at, the GPs will say, look, we'd be lost without you, really. And they're
Mm,
surprised at sort of some of the stuff that we do that they didn't never even thought to ask patients. And yeah, so I think it's here to stay, my opinion. And I'd be surprised if it wasn't. But I don't think this issue of managing these MSK issues can just be solved by FCPs. I think, which is like a lot of the work that we're doing over at Primary Care MSK, is make sure the whole workforce knows how to manage some of these common conditions effectively and reducing this sort of growing burden, which is growing each
yeah.
year. So we're here to try and help just make sure clinicians, we're not trying to train physician associates to be physios. We're just trying to get them and other clinicians to be um, better at knowing maybe what doesn't actually, well, does this patient need an X-ray? Probably not. Do they need to be put down this pathway? Probably not. Can they be managed with some simple advice most times, etc. For your common stuff we're talking here, which can make a big difference. If you make those small changes little by little, and lots of people are doing it, you can make a massive difference to the burden on the healthcare system. And then combine that with FCPs, which is like the powerhouse of managing these MSK conditions. Um, you should see a massive effect on massive positive effect on the patients and how they're managed.
Because people with, call it musculoskeletal pain, may still end or do still end up seeing at times a GP or a associate or nurse or someone, by whether there's no FCP that day or by accident or being not being directly correctly triaged or whatever it is. So obviously you've got the primary care MSK behind you. So that's not just for FCPs, that's for anyone working in primary care, is that
Yeah,
right?
yeah, yeah. So it's anyone who wants to learn more about managing MSK conditions more effectively. So we tailor a lot of our stuff. So our webinars aren't tailored to individual clinicians, but a lot of the training that we'd do to go out to a practice. So if we was to train a group of trainee GPs, it would be different to if we did a session for FCPs, because what they need to know might be different to what an FCP needs to know. And same with if we're seeing doing some stuff for some nurses or physician associates. So it's all about
Mm.
tailoring things to what they need to know as a clinician and what they'd benefit from. And then, like I say, just trying to get the whole workforce on board with how to manage the common stuff correctly, and then
Mm.
making sure that the patient is seeing the right person for when stuff is a little bit more complex and needs a little bit more in-depth work. But yeah, you're right. I mean, it depends on how many contracted hours the FCP is at the practice, because some practices might have an FCP 1 day a week, some might have them 5 days a week. It all depends on that. So it's the ones that don't have that coverage of FCPs that usually will struggle.
And is it, I'll put the website in the description. Is it primarycaremsk.co.uk?
Yeah, that's correct. Yeah.
And it has its own X and Instagram account, is that right?
Yeah, yeah. So all our handles are the same across platforms. So Instagram, X, it sounds weird calling it X, doesn't it? X,
It is.
LinkedIn. We're probably most active on LinkedIn. So Primary Care MSK. I'm quite active on LinkedIn, so just search me at Matt Wedderburn. Um, those are the main ones. We are on Facebook as well, Primary Care MSK, all the same. But yeah, best place to find out more about what we do and keep up to date with stuff would generally be LinkedIn, and our emails. So if you signed up to us to our website to subscribe to our emails, that's where you'll get most of the content that we push out and the updates, etc.
Mm. Do you think, we're talking about the future, do you think one day we'll have AI FCP?
I don't think we'll have AI FCP, but I do think there'll be a big influx of AI with triage.
Mm.
I do, and I think there's trials running now about it.
Is
I'm
there?
sure there's somewhere. I'm sure there's. I can't remember where it is. I read somewhere there is somewhere using sort of some sort of AI MSK triage. I'll have to look into it. I can't remember where that was.
Mm.
Um, but I think that will be big. But
Yeah.
I don't think it'll replace an FCP. You can't
Mm.
replace an FCP,
Mm.
because AI can't empathize and be compassionate. It can look like it, but it
You
can't
can
be.
train it to, yeah.
Yeah, you could train it. But yeah, I think that side of things is really important, and that's why you're doing a lot of the stuff you are, because communication
Yeah.
is what makes us as human and what helps us to connect, and make a big difference to patients' lives. And I don't know about you, but in my role, especially as a supervisor, I see lots of clinicians who are very, very clever, who know everything. You can ask them any clinical question, they'll get it right,
Yeah.
but can't manage patient expectations. And it's because
Mm.
they're not building that trust, they're not building that rapport, they're
Yes.
not getting to the crux of what their issue is and what the patient wants and building on that. Um, so yeah, communication skills is key. And I think people talk about getting, sorry to go off piece of it, people
Sorry,
talk
sorry.
about like communication skills like in undergrad and doing stuff. And I do believe that we should learn more about it early on in your career. I don't know what your thoughts are, but I think you almost have to go through the process of
Mm.
getting all your clinical knowledge first before you can then tighten it up with communication skills. Now, that might be a totally different view to you or others, but I think you have to know the stuff
Mm.
to know when to not sort of use it and go down that biomedical route. Do you know what I mean?
Yeah.
Um, so I think it's more for those, obviously for newer clinicians coming through, being aware of it and techniques of sort of, well, especially like utilizing ice and stuff. But as you get more experience, I think those are the clinicians that really benefit and really see the difference of communication training, because they've mastered everything else.
Yes.
That's what then tightens everything up then, and that's when you see a massive difference. That's just my personal opinion.
Yeah. I agree. My view is as well that when you're going through uni, we have this with medical students. They learn the common skills stuff. Well, at least they go to the sessions, and they do it. But as a medical student, your biggest thing is making sure you don't kill the patient. And you're not going to, prescribing the right thing, right? You're going to save their life. Uh, the building rapport and trust and all that jazz will come later. And I think they prioritize on that to make sure they're not going to do something really bad. And it's only, as you say, once you've got the clinical knowledge, you know your spiel, so to speak, we call it that, And then it's when the penny drops that actually, no matter how clever you are, how much you know, that's has very little impact on how much they like you, how much they will get better, depending on what you do. And then it's the, as you say, the common stuff, the rapport, the trust, the everything else that then people realize. And I guess that's part of the reason why I do what I do, because it's, I, like you, didn't really get anything at undergrad. You get taught what to say. You got to get taught
Mm,
how, what to ask in your subjective, but no one teaches you how to say it, how to demonstrate the empathy, how to X, Y, Z.
mm,
So yes, it's. I think there's we can teach people to do it as they're learning the clinical skills, but I think it's, as you also rightly point out, that it's the importance with the clinician really sinks, because there's ultimately is it someone to get better at, whether it's their clinical bit, whether it's the communications bit, whether it's something else, they have to see the value in it and the importance in it. And I think, from as again, it's just my experience that only once someone's in the job, got their clinical knowledge, doing their speciality, whatever, that then the penny drops. Anyway, yeah. Well, Matt, apart from primary care, MSK, is there anything else you want to plug?
uh, not off the top of my head, no. Not really. I think, like I say, a lot of the stuff that I'm doing really is on LinkedIn. We are running courses throughout the year. We've got a great one coming up with Adam Dobson. We've got another one soon to release with Charlie Clements as well, and one with ourselves. So a lot of the stuff that we've got coming up is exciting. It's good. So if you are wanting to better yourself, learn a little bit more about how to manage some of these patients and work effectively in primary care, I would encourage you to join us. And it's great because I'm learning every day with all this sort of stuff as well. So you can join me on this learning journey. But yeah, other than that, I'm not sure there's much else to plug. I think I've said enough. I'm quite boring outside of that, Ben.
Well, I'm grateful again. Thank you, Matt, for doing this with me. And I'll tell you what, every time now I have a closed question. I've gone started open and going. I'm going to lean in
There you go.
and focus, and
Yeah,
then
don't do it creepily, Ben. Don't
no,
get too
no, not
close.
no, 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 not too close, and not like a a bad guy in a movie, but
Yeah.
just like yeah. Thank you, Matt.
No problem at all. Thanks so much. It's been a pleasure, Ben.
Likewise.